Hello, welcome to the Geri Academy podcast with your host, geriatrician Dr. Golnur Sharif Saleh, providing you with information on aging-related topics. Learn more at geriacademy.com and follow me on social media. Hello, welcome to episode number 13, where we will talk about what happens in a memory clinic. I run a memory clinic, so I thought it would be important to talk about what happens in a geriatric memory clinic. Before I start that, last week I was at the American Geriatric Society meeting. This year it was virtual, which made me so sad, but also I was able to get so much information. I miss seeing my fellow geriatricians. So next year, hopefully, I'll go back. Over the next few months, I'm going to try to incorporate some of the knowledge that I gained in the meeting into my podcasts and blog posts. Stay tuned for that. I hope that you enjoy it and find it beneficial. Generally, going back to what happens in a memory clinic, when a person is evaluated in a memory clinic, they have already seen their primary care provider for an initial assessment of cognitive changes. These changes include the inability to learn new tasks, planning, memory loss, language skills, visual spatial understanding, carrying out primary day-to-day activities. Usually in my memory clinic, I see patients who are over the age of 65, but I do see some patients who are younger. People 65 and older in the United States generally have screening when they go for their Medicare annual wellness visit. Other times people are evaluated due to concerns for family members observing memory loss or caregivers seeing signs of memory loss. Primary care providers utilize standardized memory tests to assess a person for possible dementia. And if they detect abnormalities, they may send their patients to a memory clinic for further assessment. So keep in mind that dementia is often underdiagnosed and it's challenging to diagnose. If you already haven't, consider listening to the podcast, Could This Be Dementia?, to learn about the warning signs of positive cognitive decline, or read the blog post. Alzheimer's disease is the most common type of dementia, followed by vascular dementia, Lewy body dementia, frontotemporal dementia, and other dementias. And if you want to learn more, you can listen to our last episode on dementia as an umbrella term or read the blog post. Memory clinics are usually staffed by professionals who understand memory disorders, including medical doctors like geriatricians. I had extensive education on memory disorders during my training. Neurologists and psychologists also run memory clinics. Since I'm a board-certified geriatrician who operates a memory clinic with geriatric colleagues, I'm going to focus on what happens in my memory clinic. An evaluation in a memory clinic is not like a regular doctor's visit. Depending on the memory clinic process, a person can spend 1 to 3 hours during their first visit. In my geriatric clinic, we spend 60 to 90 minutes during our first session. I've noticed that my patients generally do not have the stamina to stay there up to 3 hours. And I follow this with additional 30 to 45 minute sessions to ensure everything is covered. When a first person comes to my memory clinic for the first time, we obtain a detailed history from the person. So any family history of memory disorders, history could be obtained from my patient directly, their family members or caregivers, if the patient cannot provide me with that history. It includes understanding past medical history, changes in behavior, the timeline of cognitive changes, medication history, and any recent illness. We also do a functional assessment, which includes ADLs and IADLs. ADLs is the activities of daily living. Bathing, dressing, transferring, like ambulating around, toileting, and self-feeding are things that encompass activities of daily living. And instrumental activities of daily living include things like paying bills, buying groceries, driving a car, making a phone call, preparing meals, planning and scheduling tasks. This history helps me understand the causes of cognitive changes and the severity of the possible dementia diagnosis. After a complete history and a physical examination, additional assessments are performed. And these assessments include an evaluation for depression. Sometimes depression can be confused for dementia, followed by pencil and paper testing using standardized tools. The tools that we use evaluate for deficits in attention, memory loss, abstract thought, ability to solve two-step commands, visual spatial problems, planning out tasks, orientation, awareness of time, place, and situation. Sometimes patients have a higher level of education and can compensate and practically beat the test. At that moment, I will administer some more advanced testing. Sometimes a patient may be driving, and so testing may be catered to see if the patient really understands visual spatial settings and can follow two-step commands, which are important on the road. We also look at reversible causes of memory loss. Dementia specialists look at recent blood work, the medications a person is taking, and any recent medication changes that have occurred. There is no routine blood work at this time that diagnoses dementia. However, some testing can indicate a reversible cause of cognitive changes. For example, if we find high or low thyroid states, vitamin deficiencies like vitamin B12, folate deficiency, if we find kidney disease or liver disease that may cause dementia-like symptoms, and if we can balance these things out, the patient may just feel better and they may have more resolution to their dementia symptoms. Depending on our initial finding, we might obtain some brain imaging. Usually, brain imaging is ordered on patients who present to the clinic when they're 60 years and younger, those presenting with sudden onset of symptoms, like within weeks to months. If a person has a history of cancer and there's concern that the cancer may have spread to their brain, or other abnormal neurological exams. Our imaging includes MRI, CT scan, PET scans, and keep in mind that brain imaging does not diagnose dementia, but it can help provide clues into the causes and possible types of dementia. In some instances, we may order something called a lumbar puncture, where spinal fluid is obtained, and neurologists do lumbar punctures, and also we, in our clinic, send our patients to interventional radiology, where it's a guided study. They stick a needle into the spinal cord. It's actually a lot simpler than it sounds, but we obtain a little bit of spinal fluid. And this is usually done when there's concern for more rare types of dementias. But with new emerging dementia treatments that are right now under FDA investigation and possible approval, the utilization of lumbar puncture and brain imaging using PET scans may become more routine. After our initial evaluation of our patient, the patient, their family members, and caregivers meet with me or the other geriatricians or other dementia specialists to review the testing, possible diagnosis, and treatment options. And treatment really depends on what our findings are and the diagnosis. In a memory clinic staffed by geriatricians, physicians provide extensive information and education on diagnoses, testing, and treatment. So if my visit is 90 minutes long, about 45 minutes of that visit is probably spent on educating my patient, their family, and their loved ones. During the patient visit and how the memory clinic is operating, like I mentioned, appointments can be a little bit longer or shorter, but I personally individualize the memory clinic experience. I've recognized that my patients can sometimes suffer from exhaustion when the memory clinic runs over 90 minutes. What I might do is I will break it up and say, I'll follow up with you in just a few weeks. And suppose after history taking and examination in the memory clinic, I sense the discussion with family members regarding the diagnosis and treatment is upsetting my patient. I stop the visit. I then contact family members and caretakers after the visit and review my findings. When my patient comes back for a follow-up, I review the initial assessment with them, any blood work, any testing that was done during that time. And we look to see if they're tolerating any treatments that were started, if we took patients off of any medications because I thought that those medications were contributing to their memory loss. We also evaluate to see if the patient is doing better. And after that, we may have another visit and a few weeks after that. But what I normally do is follow up with my patient at a 6-month interval initially to repeat memory testing and see where the patient is. Sometimes when we repeat memory testing, it helps us understand how rapidly symptoms are progressing, how our treatments are doing, and the stability of the patient's disease. Because for everybody, dementia progresses at a different rate, and the disease is so different for every single person. Ultimately, as a dementia specialist, we do what we need to do to support our patients and their loved ones. Sometimes our treatment doesn't come in the form of a pill. Instead, it involves extensive education, suggestion on behavioral and social modifications. We do some role play in the office. We talk about communication skills, and we coordinate care. We will see our patient in their homes if needed. Sometimes we may see our patients virtually. Our goal is to ensure our patients are appropriately treated and loved ones understand the disease process. There's data showing that patients who seek care in memory clinics end up doing better, staying independent longer at home, and the chance of institutionalization or being placed in a nursing home is reduced, sometimes prevented altogether. And this is why I really, really believe in memory care as a treatment approach. I also think that memory care helps primary care providers provide that additional extensive education and support that is not offered in a primary care setting. But there's just not possible to provide that type of care in a primary care setting when we can sit down for up to 90 minutes to talk to our patients and their loved ones. I hope you learned a little bit more about what happens in a memory clinic. If you have any questions, please feel free to email me and drop me a line. You can look us up if you're interested in a memory care evaluation. Thank you and have a great day. Thank you for listening to this episode of the Geri Academy podcast. Learn more at geriacademy.com or follow me on social media for information on future episodes.